Bismillah ar-Rahman ar-Rahim. It is my pleasure today to introduce Dr. Saeed Sanaulla. He is a consultant at Alder Hospital in Liverpool. He is a pediatric cardiac anesthetic consultant. He is very experienced. I worked with him. It was an honor for me to work with him as a fellow for a year. Dr. Saeed has a great experience in cardiac anesthesia and in pediatric anesthesia, and I would say he is one of the best that I have seen who is able to manage the IV axis for any patient, central, arterial, Broviac. I would say I haven't seen anyone better than him in my life, and he is now, thanks for him, he wants to support us and help us with the UK Anesthesia Network. So this is the first presentation for this group, and he today is gonna present to us the inotropes and the vasoactive medications in pediatric anesthesia. Welcome, Dr. Said.
Jazakallah khair, Brother Ali. Thanks for the kind words. I don't deserve even 50% of what you said, but it's okay. Thank you. Shall I share the screen?
Yes,
Ali?
yes, please, Dr. Said.
Fantastic. If you want to stop me in the middle and ask any questions, that's fine as well. Or if you want to keep the questions for the last, that's fine too. Is it okay to start, Ali? Great, fine. So, this is a topic which is very close to my clinical practice. There is use of inotropes in pediatric anesthesia. Being a cardiac anesthetist, I often use inotropes. And it's just not about the theoretical aspect of the inotropes, but we also see the practical effect of the inotropes in patients. So looking at all that over the last 10, 15 years or so, I have a few concepts which I've developed, and also with the available theoretical explanations. I'll try and give an idea about how to approach inotropic support in pediatric anesthesia. We use the word inotrope very often, and we have multiple drugs which come under the umbrella for us. But in fact, if you look at the classification of the inotropes as such, this journal in 2015, they released this classification of all these vasoactive agents. The inoconstrictors, the pure vasoconstrictors, inodilators, and vasodilators, depending upon the effect of a given drug. For example, we have dopamine, which we know has a dose-dependent effect. It can have an inotropic effect as well as a vasoconstrictor effect, chronotropic effect, similar to adrenaline, noradrenaline. So I think this is a better way of classifying the vasoactive agents. But for our discussion and for the next 45 minutes or so, I'll just stick to the word inotrope vasoactive agent. But if you look at the proper way of labeling any of these vasoactive agents, it's better to use drugs with these terminologies: the inoconstrictors, the pure vasoconstrictors, inodilators, and the vasodilators. It's in the next 40 minutes or so, we'll try and look at these different aspects of the inotropic support. First, we'll look at as to why we need to administer inotropes or vasoactive agents to a patient. We'll look at how the neonatal myocardium and the neonatal cardiovascular physiology is different from an adult. Then we also look at the molecular level, how the excitation contraction coupling happens in the myocardium and smooth muscle cells. And we look at the individual inotropes and how they think about this excitation contraction coupling and how they augment that action. We'll also look at some of the practical aspects which are more relevance to our system we have in the NHS and in our hospital. We'll also look at what would be best choice of inotrope for certain specific pathophysiological states. For example, a patient with pulmonary hypertension, or a patient with septic shock, a patient in low cardiac output state. What would be the most best approach in terms of inotropic support? Before we go into the further discuss the different things which I mentioned earlier, we'll look at this article. This is looking at the retrospective data of use of inotropes or any vasoactive agents. They looked at nearly 43,000 patients in post-cardiac surgery. And the gist of this article is that the use of vasoactive agents has been decreasing the last 10 to 15 years. The specific inotropes like adrenaline or dopamine or dobutamine or noradrenaline, the use has been decreasing, except for one drug, vasopressin, where the frequency of use is increased. It's something which is important to understand, that we are having a better understanding of inotropes and what they do and how they work. And we are finding that more than giving inotropes, it's managing around the inotropic support, which is very much the case in my practice. Over the last 10 years or so, if I look at my practice, the amount of drugs which I've been giving the vasoactive agents has gone down, but certainly the vasopressin has increased. Okay, so now why do we give inotropes and vasoactive agents? We all understand that the body has a balance oxygen delivery and oxygen consumption at the cellular. Is that okay, Ali? Then we could probably silence the. Thank you. Thank you. So the body has this balance of oxygen delivery and oxygen consumption at a cellular level. Now, this balance is broken by certain disease states, like we have the septic shock, the low cardiac output state, anaphylactic shock, and hypovolemic shock. When these things happen, we use inotropes or vasoactive agents as a pharmacological means of augmenting the tissue oxygen delivery or trying to restore the balance, which has been broken because of these disease states. So we'll just look back into the aspects of oxygen delivery and oxygen consumption. So how could we optimize the oxygen delivery? For example, you have a patient who has septic shock or a low cardiac output state. What are the things you could do to improve the tissue delivery?
طيب
So in the factors which optimize the tissue oxygen delivery, we look at the cardiac factors. The cardiac factors, we can optimize preload heart rate, we maintain the rhythm, contractility, ventricular relaxation. All this can be done by the vasoactive agents. The lung aspects, we can reduce the PVR, we can use drugs which will drop the pulmonary vascular resistance. We can optimize the mechanical ventilation. We can optimize other cardiopulmonary interactions, like we manage the ventilatory pressures, the PEEP, and also the vascular factors like decreasing SVR in certain situations where the low cardiac output state is there and the raise in SVR or systemic vascular resistance is having a negative effect on the heart contractility. Or in a child who has septic shock, we can increase the vascular tone. And neurohumoral factors. I think we are understanding more about the importance of neurohumoral factors like inflammation and thyroid balance in the tissue oxygen delivery, more so in the disease states. So these are the factors which we can look at to improve the oxygen delivery. Now, how can we reduce the oxygen consumption on the cellular level? That we can do by reducing the basal metabolic rate or the work of the breathing, by mechanical ventilation, by sedating the patients, by mild hypothermia, around 36 degrees centigrade or so, muscle relaxation, and judicious use of inotropes and vasoactive agents, whereby we are not increasing the myocardial oxygen demand. So this is a two-step approach where you're trying to optimize the oxygen delivery, but at the same time reduce the tissue oxygen delivery, reduce the tissue oxygen consumption at the cellular level, thereby trying to rebalance the imbalance which is created because of the pathological states. And how do we monitor these things? We can monitor the oxygen delivery by usual cardiac parameters like CVP, left atrial pressure, venous blood pressure, heart rate and rhythm, echocardiography, the difference between temperature at the core and the periphery, and also the tissue utilization of oxygen by measuring the mixed venous oxygen saturations, looking at the renal output and the renal parameters, acid-base balance, cerebral and splanchnic oximetry. So this will give us an idea about the tissue utilization. So overall, this is the approach. The reason we are giving inotropes and vasoactive agents, try and rebalance the issues which have happened between the oxygen delivery and tissue utilization due to the pathological states. I hope we understand up to so far. Is that okay, Ali? Is that reasonable?
Yeah, that's great, Dr. Said.
Okay. So we'll go to the next section of this talk, which is mainly looking at how the inotropes work. Okay. So we all understand at the molecular level, we have a sarcomere, which is the unit of contraction, muscular unit of contraction, which has these actin and myosin filaments, which interact to bring about contraction of the muscle. And we understand the concept of we understand the concept of we understand the concept of excitation contraction coupling as well. Okay. So Ali, can we remove this box on the right hand side? Maybe. Oh yeah, that's better.
Yes.
Yeah, I
sorry,
did.
sir, I'm working on it side, both side.
It's fine, no problem. So when an action potential travels along the membrane of the muscle cell, which is sarcolemma, there are some undulations in the sarcolemma called the TTVOs. When action potential goes through here, they are the voltage-gated calcium channels through which calcium enters into the cytoplasm. And this in turn activates the calcium channels on the sarcoplasmic reticulum, which is a store of calcium in a cell. That results in release of calcium. And this calcium, when it is released in the cytosol, interacts with the troponin C in the smooth muscle cell, in a skeletal muscle cell or myocardium. And the smooth muscle cell interacts with something called a calmodulin. When they interact, they expose the active binding sites on the actin and myosin chains and bring about the contraction through a sliding filament theory concept. So this is the normal excitation contraction coupling. But what happens when we give a inotrope? We'll look into it in a little further. But I want to just focus on the myocardium in a neonate. This the process which I described about the excitation contraction coupling depends on having first of all the myofilaments, the actin and the myosin, the mature actin and myosin filaments, the control of release of calcium from the sarcoplasmic reticulum, also the T-tubule system. All this has to be intact for the contraction coupling to happen. But in a neonatal myocardium, the myocytes are disorganized. They're not arranged parallel as in adult. The nuclei are very large, so the amount of cytosol is less. Number of mitochondria, which are the energy pockets in a cell, are less. The myofilaments are less in number, and they are not organized as in an adult. And there's abundance of non-contractile elements like the connective tissue. And the calcium handling in the immature sarcoplasmic reticulum is not optimal, as well as the adrenergic receptors are less in number. So this puts the neonatal myocardium at a disadvantage to start with in terms of coping with any stressful situation where there's a need to increase the cardiac output. Now, we all understand the Frank-Starling relationship where the preload results in increasing preload will result in an increase in stroke volume. Okay, the reason it happens is because when there is a stretch of a myocardium, myofilaments are stretched, and this stretching of the myofilaments results in the recruitment of more actin and myosin filaments. And when they contract with more pressure. That increased contractility due to the stretch of the myofilament is how the Frank-Starling relationship works. But we see here, with the increasing end-diastolic volume, the stroke volume increases in an adult heart. But in the neonatal heart, this ability is limited. The reason for that is that the ventricle is small. It doesn't relax very well. The lucitropicity, which we call, there's not much in a neonatal heart. And also, the fibers are not mature. They're not well developed. They don't have that stretch mechanism and the linking of the myofilaments. It's not advanced or not optimal as much as in an adult patient. So the response is not that much. So if you're giving fluid to a patient, to a neonate, you cannot expect the increase in stroke volume to the level that you expect in an adult heart. So as a result of that, the neonatal hearts are more dependent on the heart rate to maintain the cardiac output. So if they are exposed with a very challenging situation, they increase the heart rate rather than increasing stroke volume. And also, the afterload is very important here in the neonatal myocardium. Since the myocardial filaments are not well developed, they cannot cope with the increase in the systemic vascular resistance. So here we see the stroke volume as the afterload increases, reduces, but reduces more drastically in the neonate compared to adult. So far, we discussed about the neonatal myocardium and how it is disadvantaged because of the immature myofilaments. Now we'll look at how an inotrope, when you give an inotrope, what happens exactly at the molecular level. So here, on the neonatal myocardial cell membrane or the sarcolemma, there is a receptor. This receptor could be an adrenergic receptor, it could be a vasopressin receptor. Anyway, any of these can be done. And when they bind to say adrenaline or noradrenaline, which is a ligand, these are called ligand-gated receptors. They result in activation of the G protein binding sites on the plasma membrane enzymes. When these enzymes are activated, which could be a phospholipase C or a protein kinase, they cause further release of secondary messengers. And these secondary messengers eventually result in altering of the calcium levels in the cytosol. And that is how all inotropes work. All the inotropes and the vasoactive agents work due to alteration of the calcium levels in the cytosol. Let's look at the alpha agonist. Alpha agonist like noradrenaline. So you can consider the cell membrane as the cell membrane of a smooth muscle cell. So when noradrenaline binds to the alpha receptor, it results in activation of the GQ protein. And this GQ protein further activates the phospholipase C enzyme, which is bound to the membrane, which in turn results in release of two secondary messengers, the inositol triphosphate and diacetylglycerol. They in turn result in an increased cytosolic calcium level, which binds with the calmodulin, causing binding of the actin and the myosin and causing vasoconstriction. So this is what happens in a smooth muscle cell. And predominantly it's the vasopressin and noradrenaline which we are looking at here. Anyway, whereas a beta agonist, a beta adrenergic receptor, for example, adrenaline, will bind to a beta receptor. But depending on where these receptors are located, they bring out a different action. For example, we had the beta-1 receptors, which are located on the myocardium, and beta-2 on the vascular smooth muscle cell. When adrenaline binds to a beta receptor, this causes activation of the GS protein, which causes stimulation of the adenyl cyclase enzyme, which is bound to the membrane, which this directly causes increased chronotrophicity by activating the calcium channels and entry of calcium into the cytosol. At the same time, they also activate the cyclic AMP, secondary messenger system. This results in activation of calcium release from the sarcoplasmic reticulum, resulting in an increased calcium level in the cytosol and positive inotropicity. So all this is happening in the beta-1 receptor-related myocardial effect. Whereas if the same things happen in the beta-2 or the vascular smooth muscle cell, that results in augmented uptake of calcium from the sarcoplasmic reticulum, which results in vasodilatation. So you can look at this, depending on where the receptors are located, what types of receptors they are, they bring about different actions with the same adrenergic agent. So, for example, adrenaline Adrenaline, its effect is majority of its effect is on the beta 1 myocardium, where it brings about positive chronotropicity and anotropicity. Whereas if it works on the vascular smooth muscle, it causes vasodilatation. Adrenaline. Now we'll look at the individual inotropes and see how they interact and what is the literature or the evidence regarding these inotropic agents. So let's first look at dopamine. Dopamine is in the UK it's considered to be the first line inotropic support for a neonate coming to ICU. Dopamine. As we know, dopamine has a dose-dependent activation of the dopaminergic and adrenergic receptors at doses which are up to 2 microgram per kilogram per minute. It is known to activate the DA1, dopaminergic 1 and 2 receptors, which are situated mainly in the splanchnic circulation and the renal circulation. And it's known to mediate vasodilatation through these receptors. Whereas a higher concentration of 2 to 6 or more than 10 result in beta 1 and adrenal 1, alpha 1 adrenergic receptor activity. Now, these effects, the dose-dependent effects, are more predominantly seen in children who are older or in adult patients. Whereas in neonates, where the receptor system is not that well developed, it's difficult to appreciate that all these dose-dependent effects are happening in different doses. Also, the dopamine, about 50% of the dopamine is converted to noradrenaline peripherally. So if you have a patient who has a renal or liver impairment, because dopamine is dependent on the liver and the renal excretion, you will have a higher level of noradrenaline because up to 50% of it is being converted to noradrenaline. As a result, you will see a predominant vasoconstrictor effect even at a low dose in children who have abnormal liver and renal function. And also because dopamine also results in release of noradrenaline at the synaptic cleft. So part of its effect is through the release of noradrenaline. And this is an indirect action. And this is why you see a tachyphylaxis in a patient who's been on dopamine for a little while. And it's a common situation that we see in neonates, say, who have significant sepsis like intraabdominal sepsis with necrotizing enterocolitis, come for a laparotomy. They will be on 20 of dopamine and 20 of dobutamine. It's a common thing we see in practice, which is not I wouldn't say it's a very good practice, given that you're causing significant amount of vasoconstriction in a neonatal heart, which is compromised, which cannot cope with the increasing systemic vascular resistance. So we should always think about how much we are giving, why we are giving, are there any other things which we can do to improve the cardiac output than just giving the inotropes. Let's look at the dobutamine. We know it is a synthetic catecholamine. Its predominant action is on the beta 1 receptor, but also brings about vasodilatation to the beta 2 receptor action. At a lower level, say around 5 mics, predominantly it's a beta 1 action. As you give more and more of that, it causes a beta 2 mediated vasodilatation as well. And as we know, it has a potential to lower the systemic vascular resistance and often is used with a combination of a vasoconstrictor like noradrenaline or a high dose dopamine. Now, there's always been a talk about dopamine having a vasodilatory action on the splanchnic and the renal vasculature and can mediate renal protective effect. This is the Cochrane. Cochrane is a library which is there on the intranet. It is mainly managed by the NHS. It is a database of all the systematic reviews on different topics. So I have looked at this library, and they have this systematic review where they looked at the effect of dopamine as a renal protective agent, mainly in the neonates mainly. Often neonates are given indomethacin to close the PDAs. Now, this indomethacin, being a non-steroidal anti-inflammatory drug, can cause impaired renal function in terms of oliguria. So they looked at giving dopamine to these patients and to see if it improves the renal function. The conclusion was that there was no evidence that from all the randomized trials which have been conducted, where they looked at dopamine as a renal protective agent or improves the renal function, there was no evidence to say that dopamine has any effect. Okay, now looking at dopamine versus dobutamine as hypertensive agents, as drugs to treat hypertension in preterm infants. They again looked at systematic review, and the conclusion was that dopamine is a better drug than dobutamine in improving the blood pressure. So if you have a baby, preterm baby who has hypertension, you give dopamine, it has a better effect in bringing up the blood pressure. But if you compare dopamine and dobutamine, it's its incidence of adverse effects, there's no difference, and also there's no difference in the eventual outcomes between dopamine and dobutamine. So it's difficult to suggest that one drug is better than the other. But however, if you want to just bring the blood pressure up, dopamine seems to be a better drug than dobutamine. Let us look at adrenaline. So adrenaline, as we know, causes significant increase in systolic blood pressure. A majority of its action is on beta receptors, which are situated on the myocardium, which bring about increasing heart rate, chronotropicity, and positive inotropicity. It causes alpha-1 agonist action when you give a larger dose of drug. For example, if you're giving more than 0.1 mic per kilo per minute, you're more likely to see the vasoconstrictor effect of adrenaline. However, adrenaline can also have a vasodilatory effect in the skeletal muscles via the beta 2 receptors. But the mean pulmonary arteries are increased with adrenaline. We all see when you give adrenaline that patients are hyperglycemic. They have high lactates are high. So it's difficult to say whether the lactic acidosis here is because of the poor organ perfusion or is it related to adrenaline? Because we know adrenaline activates the beta 2 receptors in the liver, and that can result in gluconeogenesis, resulting in hyperglycemia and lactic acidosis. However, adrenaline does cause tachycardia. It increases the ventricular and diastolic pressures, and also it increases myocardial oxygen demand. We need to be very judicious with how much adrenaline we are giving. And in my practical experience, if I'm giving more than 0.1, 0.15, 0.2, beyond that, you don't see any improvement or difference by giving more adrenaline. So adrenaline is a very good drug if you want to bring it up, but it has its own side effects as well. It is known to cause provocation of tachyarrhythmias. It increases SVR, increases pulmonary vascular resistance. So you need to be very judicious about how much adrenaline we are giving. Another systematic review looking at the role of adrenaline compared to other inotropes in reducing the morbidity and mortality. Of course, adrenaline on its own, you cannot say that it improves morbidity and mortality. But however, it does increase the blood pressure. In certain situations, you want the blood pressure to be high, and we can give adrenaline, it's fine. But as a drug itself, it is not known to show any improvement in morbidity and mortality in neonates. Let us come to noradrenaline. Noradrenaline is an endogenous catecholamine, as we know. Its predominant effect is through the alpha-1 receptor, which results in increased blood pressure. And it's mainly has its effect on the vascular smooth muscle, causing vasoconstriction and increased blood pressure. And once the blood pressure goes up, it causes reflex bradycardia, and up to certain can reduce the cardiac output as well because of its increased SVR and low heart rate effect. However, it does spare the cerebral vasculature. There are not many adrenoreceptors in the cerebral vasculature. So though it increases the blood pressure, it doesn't have much effect on the cerebral vasculature. As a result, it doesn't decrease the cerebral blood flow. And that is one of the reasons why noradrenaline is commonly used in traumatic brain injuries where the patients have raised ICP, whereby it increases the blood pressure but doesn't have any effect on the cerebral vasculature, thereby maintains the cerebral blood flow rather than reducing the cerebral blood flow. So its main use is to increase the cerebral perfusion pressure. There's this article, which is a systematic review and meta-analysis looking at use of vasopressors in treatment of septic shock. And noradrenaline was considered the first line in vasopressor in treatment of septic shock, which we all know that's what our practice is. However, vasopressin is another drug which is being used more often than before. We all know vasopressin is an endogenous hormone. It is synthesized in the posterior hypothalamus and it's stored in the posterior pituitary. And when it's released, it activates the vasopressin receptors, which are located in the vasculature, the smooth muscle cells, the renal, and the pituitary. Now, vasopressin acts via the V1 receptors, which brings about the same vasoconstriction by increasing intracellular calcium levels. However, it also has this effect on the V2 receptors, where it can result in vasodilatation, which is an interesting thing about vasopressin because it has a sparing effect on the pulmonary circulation, renal circulation, cerebral and coronary circulations when it is given as a vasopressor. Its vasoconstriction action is seen more on the smooth muscle cells, but it spares the pulmonary and the renal. As a result, it is a common drug to be used in situations where pulmonary hypertension is suspected because it doesn't have a vasoconstrictor effect on the pulmonary vasculature against noradrenaline, which increases pulmonary pressures because of pulmonary vasoconstriction as well. So if you're looking at a drug to be used in pulmonary hypertension, vasopressin is a better drug than noradrenaline. And also, endogenous vasopressin insufficiency has been demonstrated in certain patients with vasodilatory shock. It is a common drug to be used both in adult patients as well as in children when we have vasodilatory shock. However, this randomized controlled trial looked at use of vasopressin in pediatric vasodilatory shock. And they looked at the dose of 0.06 units per kilogram per hour, which is quite a reasonable dose, against placebo or in addition to other vasoactive agents. And low dose vasopressin like 0.06 units per kilogram per hour didn't show any major beneficial effect in this trial. However, they also noticed that there was an increased trend towards mortality with vasopressin. There's another systematic review which looked at the role of vasopressin and its synthetic analog telepressin in preterm neonates, and they found that vasopressin was effective in treating refractory septic shock and also refractive hypertension due to any other reason. But should be very cautious when using vasopressin in patients with refractory hypertension, and end organ function monitoring is very important, like renal, hepatic, pancreatic, and gastrointestinal perfusion is very important as it causes significant vasoconstriction. Milrinone is a drug which we use routinely in cardiac surgery. And however, outside cardiac surgery, I'm not sure it has much use because the situation where you use an inotrope in non-cardiac surgery would be sepsis, and milrinone, they don't go very well together. However, it's a phosphodiesterase inhibitor. Its effect is mainly as a phosphodiesterase inhibitor, which is responsible for inactivation of the cyclic KMP. By giving, so two negatives make it positive. So it inactivates the phosphodiesterase 3, which is responsible for inactivating cyclic AMP. As a result, it results in increase in cyclic AMP, which causes positive inotropicity and lucitropicity due to uptake of the calcium into the sarcoplasmic reticulum. So positive inotropicity, lucitropicity, and vasodilatation of the peripheral vasculature because of the cyclic KMP dependent protein kinase augmented uptake of the calcium. So it is a confusing mechanism of action because it is having contradictory effects in the cytosol. But we notice that it improves the relaxation of the muscle, ventricular muscle, gives positive inotropicity, and also vasodilatation. This study was done in 2002, which was a multi-center study, looked at the use of milrinone as a prophylactic agent in patients coming out of cardiac surgery and its effect on reducing the low cardiac output state, incidence of low cardiac output state. Our conclusion of this study was that a high dose of milrinone, which is 0.75 microgram. Sorry, it's not gram, it's microgram mcg per kilogram per minute infusion, reduces the risk of low cardiac output state in pediatric congenital heart disease. However, the systematic review was done in 2015, and they looked at the role of milrinone and other drugs, milrinone against other drugs like dobutamine and levetiracetam to reduce the incidence of low cardiac output state after cardiac surgery, and it didn't show any improvement. It didn't show any beneficial effect compared to the the inotropic or the inodilators like levetiracetam and dobutamine. But we routinely use it in cardiac surgery, milrinone. We can look at some of the other drugs which have a similar effect on the cardiovascular system, which we use it often in terms of increasing blood pressure. We use phenylephrine, ephedrine, metronidazole. In our hospital, we have phenylephrine and ephedrine as the main short-term vasoconstrictors or increasing blood pressure drugs. We just use it for short-term. We don't give it as an infusion, just small boluses, and they work reasonably well for a short-term. Phenylephrine is commonly used, which is a direct agent, acts through the alpha agonist. Because of its alpha agonist action and baroreceptor reflex, it reduces the heart rate, and in fact, its effect on the cardiac output itself is maybe nothing or might be reducing. Whereas ephedrine, which is a mixed drug, both direct and indirect, results in increasing the cardiac output, and also it reduces the PA pressure because of its beta effect as well. However, it is likely to have tachyphylaxis if you're using it for a long time, and it does increase renal and splenic flow. So if you're using a short-acting, increasing blood pressure drug perioperatively in a patient who is likely to have pulmonary hypertension, ephedrine probably is a better drug. Metronidazole is has similar actions, but we don't use metronidazole, so I won't go into details of that. Steroids are commonly used. In fact, steroids are the second line of management in refractory hypertension in neonates. The way it acts is that it improves the efficiency of the inotropes by upregulating the adrenergic receptors, increasing calcium levels in the myocardial cells, and also decreasing the breakdown of catecholamines. And this is the guideline here from our PICU, where we give IV bolus of 2.5 milligram per kilogram and repeat it every 6 hours in the unit. Whereas in older children, we give milligram per kilogram every 6 hours. And there are lots of studies which have been done looking at steroids and the use of steroids in treating hypertension, and it is effective. It is as effective as dopamine in improving the blood pressure. And however, in short term, they don't have much effects, but long-term use of steroids, there's not much evidence related to it, whether they are safe in neonates and preterm infants when you use it for a long term situations. And calcium, we use it often. We use it as an emergency drug to improve blood pressure and also cardiac function. We all know that in neonates, the calcium handling is not that mature. So giving extra in vivo exogenous calcium does improve the blood pressure. And this is a study which was done in 2016, published in 2016, which looked at calcium chloride infusions. However, we prefer to use calcium gluconate because of the elemental calcium being 1/3 of the calcium chloride. And it does improve the blood pressure and the cardiac output. Neonates, more so in neonates. We can look at some of the practical aspects of inotrope administration, which I think is more relevant to our institute because every place has its own way of giving inotrope. So when we make up infusions of inotropes, we have to consider the amount of drug we are adding, what solution we are using to make up the infusion, how we program the pump. We have the Alder infusion pumps, which have preloaded programs for each of these drugs. Labeling of the syringes, how do we label them? Because the majority of patients will go to the ICU. How we manage the infusion sets, and whether we can give them centrally or can the inotropes be given peripherally as well? What drug concentrations are better than in ICU and what in theater? And why? In theaters, we make up more dilute concentrations because we often give boluses of inotropes, which is not a practice in ICU. And we want the concentration of the drug to be very low in the theaters. And if they are needed post-operatively, you have to probably do it the way the ICU like it. Orals will have issues. So this is how we make it up. We have a three-tailed connection we call the octopus. Because of this blue connections that we call the blue octopus, we put a three-way tap so that the three-way taps can be used to piggyback infusions when they're being changed on the ICU. And each of these infusion lines are labeled as well. And if you're using a 4-inotrope approach, then we put a three-way tap at the end with a non-return valve, and there the fourth inotrope can go. I just want to show it's an interesting concept of using inotropes peripherally. I mean, we always think that if you have to give inotropes, we need to have a central line. But however, that trend is again changing as well. There are a couple of systematic reviews and studies which have looked at use of given inotropes and vasopressor medications peripherally. And the incidence of complications of extravasation injuries when they've been given peripherally is about 1 to 1.8% in adults. In children, the incidence was about 3%. But the issues were when they were given for a very long time and when they're given as a very strong concentration. This study specifically looked at the concentrations of drugs which are given. Epinephrine 0.15 milligram per kilogram in 50 ml saline. So, for example, the 3-kilogram child would have had 0.45 milligrams in 50 ml saline, and that is used peripherally. And they all notice that they have given it for more than 24 hours, and that is one of the risk factors for getting extravasation injury. And this study was done in India, I think, where the resources may be limited. So in resource-limited conditions, it's safe to give inotropes peripherally, but give it for less than 24 hours and give it as a dilute solution. So in our practice, specifically in working in the NHS, the resources are not that much of an issue, but there might be some practicalities. For example, you may have an unexpected need for inotrope around the procedure where you may not have a central line in situ. In that situation, the inotropes can be given peripherally, but for a short period of time, provided the concentration is low, and we monitor the site so that if there is any sign of extravasation, we stop it. And once the procedure is done, then you have to decide whether the patient is there a need for continuing inotropic support. If that is the case, then a central line is inserted. If not, then you just disconnect the inotrope. These are all the studies I looked at, and the papers and the literature which I looked at while preparing for this talk. No, the next 5 minutes, I won't be long, 5 minutes more. I'll look at some of the individual pathological situations and what would be the best approach to managing them. For example, right ventricular dysfunction. Often we see that in patients coming off cardiac surgery, that they have right ventricular dysfunction. So fluid resuscitation is very important in these patients, and they usually like a higher CVP. Instead of 8 to 10, they might like 12 to 15. Majority of the patients like tetralogy of Fallot. And more so in the cardiac surgery, the right ventricle is not very well protected during the cross-clamp stage because being the higher ventricle, it's not that well perfused with the cardioplegia solution compared to the left ventricle. Milrinone is the first choice drug. It improves inotropicity, causes relaxation of the right ventricle. We can add adrenaline as the additional drug, and vasopressin. So this is my practice. I often use milrinone, adrenaline, vasopressin for children who have significant right ventricular dysfunction coming off cardiac surgery, and also add nitric oxide from 5 to 20 parts per million, needing more support than the 3. Pulmonary hypertension patients, milrinone infusion is a good choice. It's important that we avoid acidosis, correct with sodium bicarbonate, pro good at gas exchange, ensure adequate sedation, ventilation, muscle relaxation. Adrenaline is a good choice of drug here, and in moderate amounts, not too much, not more than 0.2 or 0.25. In that situation, you'll get a vasoconstrictor effect, and it will have an effect on pulmonary vasculature as well. And if you need a vasopressor, better to use vasopressor. So my approach is that I would give milrinone 0.5, adrenaline less than 0.1, and if necessary, add vasopressin, and gives around 0.01 to 0.02 unit per kilogram per hour. And nitric oxide, of course, 4.0. For a low cardiac output state, it's important to reduce the oxygen demand. That way, in the sense, we mechanically ventilate them, we sedate them, keep the muscle relaxed, maintain a relative hypothermia around 36 degrees centigrade or so, and give a triple inotropic therapy. Now, I've been talking about milrinone, adrenaline, vasopressin combination. Now, the idea about this is that all these drugs are working on different pathways in the cytosolic calcium augmentation pathway. Milrinone is working as a phosphodiesterase inhibitor by maintaining high levels of cyclic AMP. Adrenaline is working on the adrenergic receptor, whereas vasopressin is working on a vasopressin receptor. So all these three working at three different aspects of improving contractility. Instead of giving adrenaline or adrenaline, where you have two drugs competing with the same receptors, and they have other effects which are not necessary. For example, noradrenaline effect on the pulmonary vasculature cause vasoconstriction, whereas milrinone, adrenaline, vasopressin seems to work as a reasonable condition, as a combination. And then there is levosimendan, which is used on ICU, usually patients who are on levosimendan. Again, levosimendan is an interesting drug. It sensitizes the troponin C to calcium binding. And again, as you see, it works on a different aspect of the calcium pathway. So milrinone, adrenaline, vasopressin, levosimendan is combination. And you can add steroids, of course, steroids. We know that they upregulate the adrenal receptors, stop the degradation of the catecholamines. And then we have the septic shock patients. We have to decide whether it's a warm shock or a cold shock. And then we have fluid resuscitation, as we know, and the use of vasopressors. That's the first line of inotrope, using a vasopressor. It can either be non-adrenaline or vasopressin. And then you can add adrenaline. And of course, the steroid supplementation as well. So to summarize, inotropes and vasoactive agents, we understand that calcium, intracellular calcium, or the cytosolic calcium is the final pathway. Now, in this whole pathway, you can add drugs which have an effect at different parts, like adrenaline, noradrenaline at the receptor level, milrinone at the phosphodiesterase cyclic AMP secondary messenger level, or levosimendan at the troponin C level, or you have vasopressin working on different receptors, or dopamine. So a majority of these vasoactive agents have dose-dependent effect, and they have effect on different adrenergic receptor subtypes. And depending on where these receptors are located, they can have, same drug can have a different action. Adrenaline can have a chronotropic and inotropic action. Similarly, can have a vasoconstrictor action if it's working on the alpha-1. It can have a vasodilator action if it's working on the beta receptors. So depending on the location, which drug you're using, and how much you're giving, the inotropes will have a different effect. And children, neonates, babies, premature babies, their intracellular signaling pathways are not that well developed. Number of receptors are less, so you may not see the same effect as you see in older children. Tachyphylaxis is an expected thing to happen when you're using inotropes because there are that many receptors. If you're giving adrenaline, noradrenaline, they're working on the same receptors. It's just a matter of time before the child is tachyphylactic to those inotropes. Thereby, by giving different drugs which act on different pathways, different receptors, you can minimize the issue of tachyphylaxis. And also consider the need for steroid, calcium, and thyroid hormone replacement. So this is what I wanted to say. I'll just put the light on. It's got a bit dark. Okay, that's me. That's
Yeah, thank you, Dr. Said. That's great, really. I stayed a whole year with you, and you didn't tell me all of this. You told me about some points, but not all of it. So now I feel like you were like hiding some lots of information about me. So I really enjoyed it for myself, and I think I also enjoyed the last bit about the use of inotropes in peripherally, because sometimes we are in this situation when we are not ready with the central line and the patient needs a vasopressor. So I was like, when I use this, sometimes I use this, but I feel a bit guilty that I'm doing that. And just for this to be justified and published, and someone said that this is a usual practice that we can do, is really a great point.
I mean, in that point, I would say that it's better to have it if you think that there's a possibility patient may need algo, but you don't want to put a central line because it's not necessary. You could leave a cannula in a bigger vein, say for example, cephalic vein. So
Yeah.
better to give inotrope through a cephalic vein or a basilic vein than a wrist vein.
Okay. This is a good point as well.
It's understandable, isn't it? You had a bigger vein. The risk of causing extravasation is lesser in a bigger vein than a smaller vein.
Yeah, exactly.
So as you know,
Exactly.
when we do cath lab patients, and if you think that there's a possibility of needing inotropes, we put a long line in a basilic vein.
Yeah.
It- it-
You
So
know, one of my friends was asking me about a case, and actually, this patient, we thought that we need to make some vasoconstriction, and in the same time to maintain the low heart rate, or like the normal heart rate of the child. And I thought, what will be the options to use in this situation of the inotropes and vasopressor medications without having a central line? What do you think in this situation, how you can sort it out?
for what condition? What background?
Like this was a patient with pulmonary stenosis, uh,
Okay.
going for dilation, trying to do valvotomy with pulmonary valve,
Yeah.
and it looked like the right ventricle was very hypertensive. So we
Okay.
were worried about decreased coronary blood flow to the right ventricle. So we needed to cause some vasoconstriction, but in the same time, when I thought about the dopamine, if I give dopamine for this patient, the heart rate will be high. I'm not sure if this child will tolerate this. So, what do you think in this situation? What's your preference, without putting a central line?
Yeah. I mean, my experience in these situations is that they don't need anything usually.
Okay.
So even very severe, even systemic right ventricular pressures in
Yeah.
presence of pulmonary stenosis, they manage reasonably well.
Okay, that's
That
good.
that's been my experience. But if you're asking the question, you can give dopamine. It's fine. Dopamine will just keep everything going,
Yeah.
and you can give it peripherally happily. Or if you want, you can give a very small dose of adrenaline, just 0.05 or less than that.
Okay. Of adrenaline. Oh,
Of adrenaline,
like diluted peripherally. Do you mean in
very
this
peripherally,
situation?
yeah. Yeah.
Okay.
Or dopamine peripherally diluted as well.
Okay. That's
But
great.
usually you don't need anything.
Yeah.
You can
Um,
give some phenylephrine as well. That will take care of the effect. And sometimes calcium, just a bolus of calcium, just in the critical situation where they're trying to dilate the pulmonary artery. Just before that, you can give small doses of calcium or these kind
yeah.
of stuff.
The other thing is, I just wonder why the adults usually lean towards using noradrenaline, and pediatrics just usually try to first start with the vasopressin. I couldn't stand it. I couldn't understand it. It is just a trend everywhere that
True.
noradrenaline for adults and vasopressin for pediatrics. So I don't know if there is a reason for this, or
Well, I don't know what the reason is, but the predominant vasodilator effect with milrinone, you don't see that much in babies. However, it is a known problem, and majority of the children they have pulmonary hypertension as a another problem along with the issues they have. So vasopressin works very well in such situations. It protects your pulmonary vasculature, doesn't cause pulmonary vasoconstriction. Whereas in adults, pulmonary hypertension is not that an issue, not that much an issue. So NORAD is probably okay to use. And of course, NORAD is cheaper compared to vasopressin.
Yes, yeah.
More than 10, 15 times costlier than noradrenaline.
So
Vasopressin.
your point of that we in pediatrics usually we are concerned more about the pulmonary pressure, about the pulmonary hypertension than for the adults. So the vasopressin will be the first option. Yes, yeah,
True.
that makes sense. Yeah.
But not too much of it, just a little bit. So all these drugs, if you give it in small amounts, they have a combined effect. Like we give anesthesia, balanced anesthesia, the same approach, a balanced inotropic support, a little bit of everything, working on different receptors, different pathways.
Okay, so I think I'm just waiting if any of our colleagues wants to comment on anything or if anyone has any question, and we'll just gonna maybe wait 2 3 minutes, and if we have questions we can discuss it. That would be great.
Yes, there's a question about levosimendan. Yes, levosimendan is often used in pediatric practice. Majority of the most often it is used in low cardiac output state. So, for example, the child comes off from bypass and has low cardiac output state. Patient goes on ECMO, and we take him to ICU on ECMO. On the second or third day, if we notice that the contractility is still poor, it's not improved, then we start levosimendan on the ICU on ECMO. Because levosimendan does cause significant hypotension, hypokalemia. As a result, we don't use it in patients while they are or having a normal circulation. So yeah, levosimendan has a place in pediatric practice, and it is often used in patients who are on ECMO with low cardiac output state where the contractility is not improving, and we see the difference. It makes a difference.
Thank you, Dr. Said. So I have some more questions here. So where I can find the chat.
Regarding the regional blocks and use of drugs, sorry, Ali, is it okay if I
Yeah,
so,
go to the side. Yes. Yeah.
so, for example, we do paravertebral blocks often in our practice, and we notice, and we do bilateral, as Ali knows, and they have hypotension. But we notice that the phenylephrine seems to work reasonably well. But in an older child, I certainly use ephedrine because they already have lower heart rates. And by giving phenylephrine further drops the heart rate to an extent that you're looking at a blood pressure of 100 systolic and a heart rate of 40. It doesn't look very good in a teenager. So we often use ephedrine in older children, but in smaller children, phenylephrine seems to work very well. Use of dopamine to improve kidney function in septic shock. I mean, the amount of dopamine which would cause vasodilatation and renal, which is supposed to cause renal vasodilatation through the dopaminergic receptors, is about less than 5 microgram per kilogram per minute. And in that kind of septic shock, if the patient is low blood pressure, 5 of dopamine doesn't do anything. And if you also remember the systematic reviewers looked at the role of dopamine in improving renal functions, that concluded that saying that dopamine has no role in improving as a renal protective agent. So now dopamine in septic shock, you can use it as an initial inotrope if you don't have central venous access. But as a renal protective drug, no, there's no choice. There's no role for it. The dose of phenylephrine, you can give up to 5 to 10 mics per kilogram. But in our practice, what we tend to do is for neonates, we make up around 20 mics per mil phenylephrine and give half a mil, about 10 mics at a time. In a child who's, say, more than 10 kilograms, you can make up around 40 microgram per kilogram. And older children, say 20 kilograms plus, we make it 50 mics per mil and give a mil also at a time. Whereas in teenagers, you can give 100 mics per mil, a mil altogether. Is there a heart rate cutoff to use phenylephrine? I won't say there is heart rate, but anything which looks low is not good. Use ephedrine in such
Yeah.
situations.
Sometimes you see that the patient like hypotensive, and then the same time the heart rate is 60 or 70. So in this case, I would be worried of giving phenylephrine. Really, I will just go for something else. Yeah.
True. Ephedrine seems to work reasonably well. It's a drug which is not used that often in pediatric practice, but in fact, I think it improves the cardiac output rather than just giving you a better number like what phenylephrine does without increasing cardiac output. Ephedrine increases cardiac output as well. So I think it's a good drug to use.
I have a question, Dr. Said.
Yes, sir.
Sometimes you feel like the response to phenylephrine is not great, so you give like the usual dose that you give, and it doesn't touch the patient at all. So, what do you think at this situation? Was that like resistance, or maybe there is something else is happening, and you need to, yeah,
I mean, we understand about phenylephrine. It's a alpha agonist, isn't it? It's a vasoconstrictor.
yeah,
Now, for us to give a drug to improve the blood pressure around the anesthetic is assuming that the patient is vasodilated with the anesthetic.
yeah,
So in such situations, phenylephrine works reasonably well. But if you have a situation where the patient has impaired cardiac function, or there's something more the advanced happening, there phenylephrine I don't think does much. So there you have to think about what's happening with the heart, what's the likely cause of low blood pressure. If it is just iatrogenic low blood pressure because of a little more sevoflurane, then phenylephrine should be treated. If it is not treating, then there's something other happening as well. So you have to think about the history and look at the patient situation and deal with that.
okay, yeah. So there is another question. One of our friends is asking about hypotension with bradycardia in patient with severe aortic stenosis. I suppose we will consider this a child first. And
No, I didn't get the question. What is it? Is it hypo?
hypotension,
Uh-huh.
hypotension with bradycardia in patient with severe aortic stenosis. What we're gonna like use? What will be the first option of
Oh,
the, yeah,
oh, okay, okay. I would give a titrated dose of ephedrine. Titrated dose of ephedrine. Okay? Not too much of ephedrine to drop the heart rate too significantly, but also to increase the heart rate too significantly. But just depends on how bad the hypertension is as well. Okay?
yeah,
Now, also the severe aortic stenosis, how severe it is, and what you're trying to achieve, whether it's a patient going for cardiac surgery, pre-bypass, you're just trying to hold the procedure till the patient goes on bypass, where you can use bolus of adrenaline as well, up to certain extent to improve the thing. And also look at the background history of whether the child has a preserved function with severe aortic stenosis or not. So there you'll have to think about what drug to use. So in such situation, if the function is poor with underlying aortic stenosis, ephedrine probably is a better drug. It improves the cardiac output as well, and it has an inotropic effect as well up to a certain extent. Compared to phenylephrine, it just causes vasoconstriction. It does nothing much. I
yeah,
understand where they're coming from, or the role of heart rate and severe aortic stenosis. Yeah, I understand. It's a tricky situation. It's difficult to give a this is right answer. You have to look at the clinical situation as well around that time, which we all do, I'm sure. Which we all do.
uh, I can't thank you enough, Dr. Said, for your help and support and taking from your time. I know that you're a busy person. I know that I destroyed your weekend, and thank you for that. You,
It's a pleasure, Ali. It's a pleasure. I feel honored speaking to all our colleagues from a different country, and it's an honor to
yeah,
be part of
and
the program.
yeah,
Thank you.
and thank you for everyone who attended the presentation, who showed his support to us. And we invite all the people who are not on the group on the UK Anesthesia Network to be in the group, on the Facebook group. And also, I will try my best because it is like an easy way to share the Zoom meetings and the invitations for the meetings. And if you please, anyone who is not in the group, if you please can join the group, that would be great. And thank you for all your help and support. And thank you for Said.
Thank you, Ali. And
Yes.
I hope everything goes well for you, and I hope all, I don't know how the delegates in the talk, what stage of career they are, but I hope they all reach their goals,
Yeah.
and
Thank
Allah
you.
make it easy for them all.
Yeah. Thank you very much. Thank you.
Take,
Assalamu alaikum. Assalamu
have a
alaikum.
good weekend, inshallah.
Bye.